Okay, looking at head and spine injuries. I'm sure we are all aware of a lot of incidences where persons would have been impacted with injuries to the head and our spine, and these have serious implications. So as advanced personnel, we need to know about the systems that are involved and how they can be impacted, and the best approach to providing care for these patients. Again, you would have looked at the human body and the nervous system, which would be a part of the system dealing with the head and spine. So basically just be going through a refresher. So the nervous system is a complex network of nerve cells that enables all parts of the body to function. So it is the, you would say it's the controlling system of the body. And you have the central nervous system, which is made up of the brain and the spinal cord. And then you have the peripheral nervous system, which is made up of the other nerve impulses. As it relates to head trauma, there are some terminologies that you need to be aware of, and in the past they were having some issues with how they should classify certain injuries, and some injuries were being missed because of how they were terming them. So they have come to this point where they are associated. Once we are saying head trauma, then we are talking about both injuries to the head and traumatic brain injuries. And a head injury is classified as traumatic injury to the head that may result in injury to the scalp and our head or skull. So that's a head injury. For a traumatic brain injury, it's gonna be injury to the brain caused by an external force. So those two would be what they would refer to as head trauma. So they have placed spinal cord injury in a section by itself, which is one of the most devastating injury. So once it's spinal cord injury, they're not going to be grouping it as head trauma. It's in a grouping by itself. So you need to recognize these groupings or classifications of the types of injury when we're talking about head and spinal injury. Again, we'll be just running through the review of the anatomy and physiology of the nervous system. We mentioned that it's divided into the central nervous system and the peripheral nervous system, and you have voluntary activities or actions that we consciously perform, while involuntary actions are actions that are not under our conscious control. So the nervous system is further divided into the autonomic and the somatic, and that's where you have the voluntary actions that would come under the somatic, and the involuntary activities would come under the autonomic nervous system. And again, we see the breakdown there this is basically a review you should have looked at in human body. Another structure you need to recognize the anatomical structure of as it relates to head and spine injury is that the fact you have the cranium and the face, which would make up the head. So you have scalp is the subcutaneous tissue, contains the major vessels supplying the scalp, and the head, the skull, has cranium and facial bones. We looked at facial bones previously, so we are going to be focusing on the cranium more so. And just to go back, just let us look at just look back at the anatomical structure. Okay. So the brain connects to the spinal cord through a large opening at the base of the skull called the foramen magnum. You need to remember that opening. That's the only opening you will remember that is contained within the skull. And that's a very important thing to remember going forward. 4 major bones make up the cranium. So you have the occiput or the occipital bone, that is the most posterior section of the cranium or the head back. Temporal regions or temporal bones, lateral portions on each side of the cranium. And you also have the parietal region or parietal bones, region between the temporal region and the occiput or occipital bones. And the last section is the frontal region or frontal bone. We need to recognize these 4 areas or regions. So we mentioned earlier on that the face is composed of 14 bones. You have the maxilla, which are the upper non-movable jaw bones. Cheekbones are called zygomas, and the mandible, which is the lower movable portion of the jaw. The eye socket is made up of the frontal bones of the cranium and 2 facial bones. The nose mostly consists of flexible cartilages. This is just review. We basically run through this already, so we'll move on. Just remember that we are talking about head and spine injury. As it relates to the spine, it is consisting of 33 irregular bones or vertebrae, as they are referred to, and they articulate to form the vertebral column. So all of these 33 bones are stuck together, and so they form the vertebral column, and within that column you would have the spinal cord would flow in through that column. Vertebral body is made up of bone that provides support and stability. So these are the bones that are going to protect and offer structure and support upward, upright posture and all of that. Spinal canal encases and protect the spinal cord, as we mentioned, and you can see the different areas of it. So posterior, you will have the bony arch, spinous process, transverse process, and anteriorly you will have the spinal, the body, which will connect the rib cage. As we look at head and spine injury, as we look at the head and spine injury, remember that the spinal canal is intervertebral disc will separate each vertebrae and act as a cushion, and the vertebral column can flex and extend substantially, but there's a limit to how far it can reach. So there's a limit to its range of motion, which will be set by the ligament and the muscles that connect it. Therefore, if it's stretched or extended beyond its range, then it can result in injury. Peripheral nerve injury at the peripheral level. So you need to have an appreciation of the anatomy and the physiology of the nervous system and the brain and spinal cord, spinal canal. So for the central nervous system, we said it consists of the brain and the spinal cord. So the brain is the center of consciousness, most metabolically active and perfusion sensitive organ. So it needs a constant supply of blood. It's always a lot of work going on. It's the center of consciousness. As he said, it's the powerhouse of the body. A lot of persons will say what are important in their body, but we should recognize that the brain, very important organ. So these are the divisions, and so we have the, just as how you have the cranium have the lobes or have the regions, is the same thing with the brain. And so you have the brain is divided into the cerebrum, the cerebellum, and the brain stem. And we say the easy way to remember which is which. The little word is actually the major portion of the brain, and that's the cerebrum, is responsible for higher functions, divided into right and left hemisphere. And we know that the left hemisphere controls the right side of the body and vice versa. So you will have the front of the cerebrum is your frontal lobe. The rear is the occipital lobe, and the temporal lobe to either side, and the parietal lobe at the top section. So remember, and each area carry out different functions. As we said, this is a quick review. We want to get to the core area, which is your pathophysiology. But you need to appreciate the anatomy and physiology to have a better appreciation of what is happening when a person is injured. The cerebellum coordinates the body movement. So this is a second section of the brain, and the brain stem controls virtually all functions that are necessary for life. The spinal cord transmits nerve impulses or signals between the brain and the rest of the body. So just remember those pointers. Again, we have the spinal cord encased within the spinal canal, and also the brain. You have what you call meninges. These are protective layers that surround and enfold the entire central nervous system. So it acts as a protective layer, as a shock absorber, and you need to know that it has 3 layers. So you have the arachnoid, the durameter, and the pia meter. Those are the 3 layers. And for the peripheral nervous system, you have 31 pairs of spinal nerves and 12 pairs of cranial nerves. So the cranial nerves are what have our sensory controls and innervates the head and face, while you have the 31 pairs of spinal nerves, which supplies the rest of the body with nervous control. Again, we are just doing a revision, so you would have gone through this in your human body. The somatic nervous system, as we say, that's the area that regulates voluntary activities, while the autonomic nervous system controls the function of many of the body's vital organs. The cranial nerves pass through openings in the skull and transmit sensation directly to or from the brain. So the cranial nerves bypass the spinal cord, and so they directly innervates the areas of the head and face without having to go through the spinal cord. And you need to appreciate that when we are dealing with injuries to the spinal cord, it would not affect the impulses of the cranial nerves. Peripheral nerves conduct sensory impulses from the skin and other organs to the spinal cord. So you have motor nerves would respond after the impulses carried by the sensory nerve to the brain, and it relays the information. You can have vice versa, where you have a reflex action, heat applied to the body, and the motor nerves will, the sensory nerve will pick up the signal and transmit it to the brain, but you have what we call a connecting nerves, which will act as a shunt, so it doesn't have, the signal doesn't have to go to the brain per se, but it is shunted immediately to a response back to the motor nerves, and the person will pull their hand away from the heat source. That's how that will work, and we all should be aware of that. We are continuing with the anatomy. The autonomic nervous system, we say, is this section that deals with involuntary functions, and it have sensory and motor nerves often overshadow the role of the spinal cord. So the spinal cord gonna be carrying the signal from the brain to the peripheral nervous system, and it's the motor nerves and the sensory nerves which will act as their relay to carry the information to and from the spinal cord, which is coming from the brain ultimately. So the autonomic nervous system is divided into the sympathetic nervous system, which controlled by the brain's hypothalamus, and the parasympathetic nervous system, responsible for conserving energy and maintaining organ function. So the sympathetic nervous system speed up things, and the parasympathetic nervous system slows down things. This is just background information. We need to get to the real injuries that we want to be focusing on, but your knowledge of anatomy and physiology will always help you in recognizing what is going on when we have these injuries and how you need to treat them to have the best result for your patient. So let's look at the pathophysiology. So now that you have that appreciation of the anatomy and physiology as it relates to the head and spine injury, which should be focusing on the nervous system, we are going to be looking at the injuries that can occur to the head and spine, and how you will see the symptoms, the signs, and hear the symptoms from your patient. So head injuries, as we said earlier on, would be traumatic insult to the head that may result in injury to soft tissue, bone structures, or the brain. Closed head injury results in skull fractures, focal brain injury, diffuse brain injury. So the overlaying scalp is not broken, but you have damage to underlying structures. That's a closed head injury. For the open head injury, durameter and cranial contents are penetrated, may leave a neurological defect. So In this case, you have compromising of the brain. So you could say, let's start with the simplest of the injuries that can occur generally to the head and spine. You can have a scalp laceration, and it's a small laceration can quickly lead to significant blood loss because the scalp is very vascular, a large supply of blood vessels and blood, so it can bleed a lot when it is damaged, indicator of deeper, more serious injuries. So in any musculoskeletal injury, once there is damage to the outside, suspect that there can be serious underlying injuries, and it can be guided by your mechanism of injury, which will give you that index of suspicion. So moving from a scalp laceration, it can get worse where you have now a skull fracture. Skull fracture may be open or closed. Signs include patient's head appears deformed, visible cracks in the skull within a scalp laceration, ecchymosis, bruising. All of these are things that should clue you in that this is a possible skull fracture and should not be taken lightly. We are always going to be thinking the worst in the pre-hospital setting because we don't have all the resources that we need out there to do the best for the patient. So always err on the side of caution and think the worst and take appropriate action. So they have different types of skull fractures. It can be linear skull fracture. So in this case, non-displaced skull fracture. So there is no deformity involved, would be noted. It's more than likely it's X-ray radiological would be determined. You can have the next level depressed skull fractures. Bony fragment may be driven into the brain, resulting in injury, so it gets worse. You can have basilar skull fracture associated with high energy trauma. So the deeper areas of the skull is fractured. Moving from a linear, you could go to a basilar open skull fractures in which you have brain tissue may be exposed to the environment. So all these are types of skull fractures, and they will determine the significance of them. So we see some examples of the linear A. You will see a mark, but most of the time we are not going to be seeing that mark. So it's going to be, like I said, when they go in for further analysis and X-ray and CT scan, those sort of checks will reveal. From our point of view in the field, you might not even notice that. For the depressed, an area will be depressed, so in your assessment, palpation, gentle, you will feel it or see signs of it. Basilar, we say it's a deeper area of the skull being fractured and can lead to open exposed brain content. So all these are types of injuries that we can have to the skull. We continue to look at traumatic brain injuries. It's primary brain injury. So we said there head trauma is consisting of head injury and traumatic brain injuries. So we looked at the head injuries before. Now we're looking at traumatic brain injuries. So primary brain injury caused instantaneously from impact to the head. So as the person get the blow, this is what gonna be that primary brain injury. Secondary brain injury is as a result from the sequence or the impact of the primary brain injury. So it is something else happened after you have had that primary insult. What can happen from the secondary, which will be secondary brain injury? You can have cerebral edema. And when we looked at the skull, we said there's only one opening in the skull, and that is the foramen magnum. Hence, if you can also have intracranial hemorrhage and increased ICP, increased cerebral pressure. So if there's the skull is actually like a vault in some respect, except for that opening. Hence, the pressure is going to build up, and it causes the increased ICP. Cerebral ischemia and hypoxia can also result, where you can have blockage and low oxygen results from it. You can have infection, where you have open exposed brain content, result in infection, contamination, and you can have hypoxia again with hypotension. So all of these are secondary brain injury as a result of the primary injury from the actual force that will cause the different types of skull injury. So brain can be injured directly by a penetrating object as a result of external forces exerted on the skull. And we see that in a motor vehicle accident, various ways. You can have it gunshot wound. Injured brain swells initially because of cerebral vasodilation. So swelling in the brain, and you will have that because of the dilation of the cerebral vessels. As we continue to look at the pathophysiology, problems that can occur with head and spine injury, an increase in cerebral edema then contributes to further swelling. Low oxygen levels in the blood aggravate cerebral edema. Appearance of clear or pink watery CSF indicates that the dura and skull have both been penetrated. Once you see that cerebrospinal fluid, it indicates that both the meningeal layer and the skull have now been compromised or penetrated. And we have the Cushing triad, signs produced by the effects of cerebral edema and increased ICP. So what are the Cushing's triad? These are a combination of signs that you will see to suggest that the pressure has been increased in the brain. So you will have hypotension. The patient's breathing will become irregular. And also the heart rate will elevate. So the intracranial pressure is the pressure within the cranial vault. Bleeding inside the skull increases ICP, and increased ICP squeezes the brain against the cranium. The cerebral perfusion pressure, CPP, is the pressure of blood flow through the brain. So there is a pressure within the brain. As we say, it's like a vault, and in order for the blood to flow to the brain, it's gonna flow against that pressure. So the resultant pressure is gonna be your cerebral perfusion pressure, which will be causing the blood flow in the brain. And so you need to recognize it. So the body will attempt to regulate its blood pressure to maintain a flow that will be able to innervate the brain, and that is auto-regulation. So the body responds to a decrease in cerebral perfusion pressure by increasing the mean arterial pressure. So that is the normal pressure that you will have circulating the body, resulting in cerebral vasodilation and increased cerebral blood flow. So that is how the body or the brain will compensate to ensure that you will have an adequate cerebral perfusion pressure to maintain adequate blood flow to the brain to supply the cells of the brain. If increased ICP is not promptly treated, cerebral herniation may occur. And so if the pressure continues to build up, ICP continue to raise, then we say there's nowhere else the brain matter can go but through the foramen magnum. And that's where it's gonna herniate, and that's where you have compression of the brain stem, the point where it exits and merges into the spinal cord. That will become compressed and you have all sorts of problems occurring. So it's very important that we recognize what is happening and provide the necessary care to help with that issue. Ultimately, we need to get that patient to where they can get the definitive care. So monitor for signs and symptoms of increased ICP. One indication will be the patient will exhibit decorticate posturing, meaning that they are going to be flexing the arms and extension of the legs, as we see in the diagram A. So that is not as bad as the cerebrate flex posturing, which is extensor. So in this case, they are extending the arms and the legs. This is a worst case scenario than if they were having the decorticate. And the word you can use there are the phrase in the sentence to remember both of them. Core, decart, core, that would be for the flexing. They flexing their arms to their core, while the cerebrate is the extension. Once you know one, you will know the next. So focal brain injury is specific and grossly observable brain injury. You can have cerebral contusion. We are talking about traumatic brain injury. You can have cerebral contusion, which is brain tissue is bruised and damaged in a specific area. You can have epidural hematoma, which is bleeding outside of the dura, accumulation of blood between the skull and the dura meter. You can also have subdural hematoma. This is when the blood is going to be collecting below the dura. and that would be below the dura and the arachnoid, between those two layers, but it's gonna be outside the brain, so it is not impacting the brain in this case. So it's classified as acute, subacute, or chronic. And you can see the example there. So it all depends on which blood vessels are affected. You can also have intercerebral hematoma. This is when you have bleeding within the brain tissue itself. And you can have subarachnoid hemorrhage. Bleeding occurs into the subarachnoid space. This is where you have the cerebrospinal fluid circulating. And that's why we said if you see CHF, then that is telling you that the skull has been compromised and also the dura meter, because the next layer would be the arachnoid space, which contains the CSF. You can also have diffuse brain injuries that affect the entire brain. So you can have cerebral concussion. Blow to the head or face may cause a cerebral concussion if the brain is jarred around in the skull. So this is a mild traumatic brain injury. This is where you would say the person just have a temporary loss of function and then they are okay. So there is no structural damage to the brain. But it can get worse than that. And for the common features of the concussion is when you have results in the rapid onset of short-lived impairment of neurologic function that resolves spontaneously. So just for a period, they have loss of function. They might say they are feeling they dizzy and all of that, but after a short time, they are okay. So results in neuropathic changes. Signs of a concussion include confusion, disorientation, and retrograde amnesia. So retrograde is they cannot remember the things that happened before the injury. Ask about symptoms of concussion in any patient who has sustained a head injury. Again, we still want to encourage them to go and have themselves checked out, because even though they would appear normal, we're not sure if there can be other underlying issues that are not showing up right away or can come back later. Another type of traumatic brain injury is diffuse axonal injury, and we know that these are the ending of the nerves impulses, so they can become injured, and this is a more severe brain injury. So now you have structural damage, often associated with a poor prognosis. So once this happens, chances of they coming around is slim. So severity and prognosis of diffuse axonal injury depends on the degree of damage, classified as mild, moderate, or severe. Again, this is what we say happened as a result of the primary insult. Spine injuries. So spine injuries the spine can be injured in a variety of ways. You can have compression injury from a fall. You can have motor vehicle crash or other types of trauma. Person can have, it can be a attempt some hanging situation, or distraction injury. Mechanism of injury would be flexion injuries, result from forward movement of the head, typical from rapid deceleration or a direct blow to the occiput. As we said, the spinal canal is there to offer protection to the spine, but we said if the movement is beyond the range that it can tolerate, then it's going to result in injury. And you can also have caused from rotation with flexion, result from high acceleration forces. It can also occur from vertical compression. Forces are transmitted through vertical bodies, and we said you have the intervertebral disc, but they can also be overwhelmed and you can have injury to the vertebrae. So typically result from direct blow to the crown, parietal region of the skull. So right immediately at the top of your head, rapid deceleration from a fall, compression forces can cause herniation of disc. So you can have indirect blow, you fall on your foot and the force transmitted up through your spinal canal and also impact the spine. So compression forces can cause herniation of disc. Hyperextension and distraction, as I said before, in case of hanging and neck, can result in fracture of bones and injury to ligaments. Distraction occurs from rapid hyperextension of the skull, atlas, and axis as a unit. So all of those vertebrae can be impacted and resulting in the spinal cord being compromised. Spinal cord injuries, obvious injury to the head, neck may indicate injury to the cervical spine. And depending on where on the spine the damage is, will determine as to whether the person become a paraplegic or a quadriplegic. So for upper extremities and lower extremity to be impacted, the injury would have to occur above C5 and C6, cervical spine 5 and 6. If the injury is above there or within that region, then the person will be a quadriplegic. They will have paralysis to both upper extremity and lower extremities. All of that region will be impacted. For a paraplegic, means just the lower extremity will be affected, then it would be once it's below lumbar spine 1. So primary spinal cord injury occurs at the moment of impact, just as with the brain, and the spinal cord concussion is one example where you can have it is characterized by a temporary dysfunction that lasts from 24 to 48 hours. So similar to brain concussion, cerebral concussion, you can have spinal cord concussion where the impact occur and you have loss of function temporarily and it comes back within a day or two. That would be a concussion. But you can have further damage, structural damage, where you have spinal cord contusion is caused by a fracture, dislocation, or direct trauma. You can also have secondary spinal cord injury result from primary SCI progression too. So spinal cord injury can progress to further deterioration. And so you have minimizing heat loss and maintaining oxygenation and perfusion are key. So once there's a spinal cord injury, remember the function would be lost below the point of injury that would normally be had via the spinal cord to those areas. So they will not be able to maintain their body temperature. So as a provider, you will have to do that for the patient. So maintain their heat loss and their response to their phrenic nerves to supply the diaphragm. Also the intercostal muscles can be lost, so they will not be able to breathe properly. So again, we will have to maintain their oxygenation and perfusion are key. spinal shock occurs immediately after spinal trauma, and so you have sensory functions below the level of injury will be impaired. You have neurogenic shock, which you would have dealt with when you're dealing with types of shock. So it's a result from the temporary loss of autonomic function. So once there is injury to the spinal cord, then the function will be lost, and you're going to have widespread dilations of the blood vessel, vasodilation, and we know that that's going to result in hypertension. So hypertension occur. Classic case of neurogenic shock is a hypertensive bradycardic patient. So the stimulation cannot be maintained via the spinal cord, and so that's the result. Recognize that. Or you will recognize also the, so instead of the patient cool and clammy, that patient will be warm. So we have looked at the anatomy, physiology, and pathophysiology of the head and spinal injury. We're going to look at the patient assessment, and we say that patient assessment will always be patient assessment. So general patient assessment is start with your scene size up. We're talking about head and spine injury, so the focus is going to always be on safety. Ensure that the scene is safe. You will be called to motor vehicle accident scene. Ensure that you check whatever possibilities are there to create harm for you, your partner. All of those must be taken into consideration. So decide whether this trauma system should be activated. So again, we say what resources you're gonna need. You're already advanced, so decide if you think you'll need paramedic backup. Think if you need to activate airlift. Look at those things and decide on them from early. Again, we say it's your platinum 10. You need to get that patient with significant trauma to the head and spine to the receiving facility where they can get the definitive care that you cannot provide for them unseen. So the sooner you can get them off is the better. So put all of those things in place. Consider the need for a permanent backup. Refer to high-risk mechanism to determine the possibility of spinal injury. You're always gonna think the worst case scenario. Once you suspect it, think that it is there, take the appropriate actions to do what's best for your patient. Again, your precaution will be important. In this time, we say your mask, your face mask, and your gloves. Take whatever else you need to put on as your BSI and standard precaution. Know the number of patients, and especially you go on motor vehicle accident scene, you might be called for one person and there are more patients there. You have to decide whether you can manage with your team that you go with. So you move from your scene size up to your primary survey. Ensure that you do your general impression, see, have an idea of the patient. You're gonna continue with your XABC or your DE or your ABCDE, whichever is appropriate. Ensure that manual stabilization, which you'd have suspected of the patient having a spinal injury, is taken, and maintain manual stabilization. Focus on identifying and managing live threat. So once you have gotten your general impression and your check LOC with manual stabilization, if indicated, then you're gonna move to your live threats. You must deal with your live threats, and we say if there's exsanguinating bleeding, it's gonna be the priority to stop that bleeding. So X, then you move to A, or if you want to say CAB. In case you're cardiac arrest, then you need to use that CAB. Life-threatening external hemorrhaging must be treated before airway and breathing concern. So we know that is ABC normally, but once there's exsanguinating bleeding, if you're gonna be focusing on airway, the person might not have any more blood for you to work with after you fix that airway. In your primary survey or your primary assessment, you are going to use your AVPU mnemonic to evaluate the patient's LOC, level of consciousness, and note the appropriate response. Unresponsive patient with any trauma should be assumed to have a spinal injury. So if you find someone and they cannot tell you, nobody can tell you what happened to them, think the worst, that they have a spinal injury. Always, it's gonna be for your primary survey, your ABCDE. Airway management in patient with head or spinal injury. You're gonna ensure that you have a patent airway. So if there is gurgling, suspect fluid, you need to clear it. Spinal injury suspected, turn the patient out of unit and get it out. Suction as needed. After opening the airway, be prepared to roll the patient to the side to prevent aspiration. We have to ensure that we have a patent airway. Not a patent airway, you don't have a patient. So manually remove any large debris from the patient's mouth if it is safe to do so. No blind sweeps. Use suction to clear secretions. Open the airway with the jaw thrust maneuver if patient is unresponsive. So meaning once you suspect spinal injury, you're going to employ a jaw thrust. But again, if you're using jaw thrust and you're not able to maintain the airway properly, it's best to do what is needed. At the moment, it's going to be what can get that airway open most effectively. So an intact gag reflex is a contraindication for a oropharyngeal airway, which is a given. At this level, we should all know that a nasopharyngeal airway should not be used if a basilar skull fracture is suspected or if there is nasal trauma, because you're going to run the risk of it being entering the brain, and so it's a contraindication. Ventilation in context of head or spine injury. Evaluate the patient's breathing, noting the rate, depth, and symmetry of each respiration. Ventilate the patient to maintain the end-tidal CO2. And so once you have dealt with the airway, once you have managed the airway, and you have reached to your breathing, you want to ensure that if the patient needs to be ventilated from your assessment, then you provide that ventilation. So ideally we want to have that O2 saturation between 94 to 98%, and also you would assess circulation and volume resuscitation in a patient with head or spine injury. Again, we say because of the autoregulation, you might have changes in the blood pressure. So initiate cardiopulmonary resuscitation if it is needed. Volume resuscitation may be necessary. Again, as an advance, you would be establishing your IV access. Ideally, you would want to try to get 2 lines in, largest bore possible based on your patient, and also assess radial pulses. You want to assess for signs and symptoms of shock and treat appropriately. Very important. And also assess your pulse pressure. You need to decide from early whether to complete the secondary assessment unseen or to transport the patient immediately with interventions en route. So once you have gone through your A, B, C, D, disability. By this time in your primary survey, you should have established your patient GCS. Also, you need to do your rapid scan for a significant MOI, meaning that the patient can have multi-system trauma. So you must search the body to find out if there is any other life threats before you package that patient and move them. And also, you would have decided if this is a patient that you can stay and play with, or you need to get that patient off within your platinum 10 minutes for definitive care, which we say in most cases they're going to need surgical interventions. So you must do your ABCs, manage them, and prioritize your patient, do your rapid scan, fully mobilize, and package your patient to move them from that scene. In supine patients, the head should be elevated 30 degrees, and remember to maintain immobilization of the spine. Once we have completed our scene size up, your primary survey or primary assessment, then it's gonna be your history taking. Again, we say for our trauma patient, you might not be able to get much history, but don't tell yourself that you cannot get any history. You always have to think about your history, because we say that the patient could have had a medical condition which led to them having a trauma issue with the head and spine. So you will always attempt to investigate the chief complaint. We're going to use our OPQR ST mnemonic, obtain a medical history, and be alert for injury-specific signs and symptoms. Get your sample history, which will give you further information as to the patient, what could have led up to this that is happening to them. Make every attempt to obtain this sample history. As I said before, a patient is unresponsive. Don't tell yourself that you cannot get any history. You can get history from family member, bystanders. The patient themselves can have a medical alert bracelet or card in their wallet or pocket. Check on those things. But the focus is, especially with your trauma patient per se, is your primary survey. You're gonna move to your secondary survey or secondary assessment, in which you're gonna be obtain a complete set of vital signs using your monitoring devices, your pulse oximetry, your end-tidal CO2 reading with your capnography. You're gonna be getting your full set of vital signs, modify physical examination of any patient with suspected spinal cord injury, apply manual stabilization while asking the patient not to move, and all of that you would have been doing from initial in your LOC check. Basically, you're gonna be doing a focus examination if it's indicated, or if time allow you, do your full body scan. Again, we said most instances, if you are caught up with life-threatening situation with ABCs, you might not have time to do a full body examination, estimate the severity of the increase in ICP. So again, be aware that the patient can be having raised intracranial pressure. It's very important that you establish the GCE for your patient. Again, this will come in the D for disability. You should get an idea of, or I would say must get your patient and your primary survey, at least by the end of the primary survey, you should establish what your GCS on your patient. Always use simple, easy understood terms when reporting. Expose the patient to examine the spine, and we'd have exposed to get your rapid scan of the anterior body first. And then remember, if you expose, you should recover, especially if your patient having signs of shock. You need to treat them appropriately for that, covering them. Use your pneumonic decap BTLS once you're doing your rapid scan, and we said you would have started the rapid scan for a patient with significant MOI from your primary survey. At least at the end of your primary survey, you'd have done that rapid scan to decide from there if they are having any underlying issue, injury that you would have picked up before you attempt to package and move your patient. And you need to have decided if it's a load and go patient that you're gonna stay and play, or you need to move them. So if it's a load and go, the secondary assessment would have been taking place en route or in the ambulance at least. So secondary assessment continues. A spinal cord injury may also produce pain independent of movement or palpation. So even without moving the patient movement, or you touching the patient, they can have pain from that spinal cord injury. Evaluate the chest and abdomen for both internal and external injuries. Auscultation to assess breath sounds may reveal a shortened inspiratory phase. Use monitoring devices to quantify oxygenation and circulatory status. So all of that you'll be doing in your secondary assessment, and depending on your patient condition, it might be done unseen, or you more than likely will be doing this en route in the back of your ambulance. Continually monitor the cardiovascular system for signs of shock. Examination of the gastrointestinal system may be unreliable in the presence of a neurologic deficit. Look for any abnormal posturing, and that we say will show up with indication of a raised intracranial pressure. Your decerebrate and the corticate posturing. Use a glucometer to assess blood glucose levels. And that's your general patient assessment. As it relates to emergency medical care for the specific injuries that is related to head and spine injury, these are what we will be doing. The last part of the reassessment, you would, for reassessment, that's the last part of the patient assessment. You would need to reassess your patient starting from your primary survey. Basically, you're doing over what you have done for your patient. And so you will look back at the ABCs, LOC ABCs, vital signs, chief complaint, interventions, whatever you had done for the patient, check back and then make sure that they are working, or if they need any adjustment. You had control bleeding, check back on the bandages. If the bleeding has started back, you need to do something about it. You're giving oxygen, the tank could have finished and you're there driving along and assume that oxygen is still flowing. So vital signs should be monitored frequently. Repeat your vital signs. For a unstable patient, it's gonna be every 5 minutes you need to do your reassessment. For a stable patient, it's gonna be every 15 minutes. Spinal cord injury responsible for neurogenic shock also usually produces a flaccid paralysis and complete loss of sensation. So similar to the raised intracranial pressure, it can give you that effect where you have that almost a decerebrate posturing. Hypovolemic shock is associated with pale, cold, clammy skin and tachycardia. So if it's a shock due to blood loss, then you will have that classic presentation. If it's a shock due to, if it's a neurogenic shock, then you will not have that classic presentation. So you need to recognize it. The skin will not be cool and clammy. So you're able to have an idea. Treat the patient with a head injury according to 4 principles. So these are the principles that should guide us in the emergency management of a head injury. establish an adequate airway. So all the times, in every case, it's gonna be your airway will take priority. If you don't have a Are you hearing me? Are you hearing me? Okay, sorry about that. I had a temporary loss of connection. Okay, so we are looking at the emergency care for head injuries. Establish an adequate airway, that is paramount. You're gonna ensure that you control bleeding and provide adequate circulation to maintain cerebral perfusion. Start at least one 18-gauge intravenous line and administer an isotonic crystallite solution as needed. So your choice fluid would be your normal saline. Assess the patient's baseline level of consciousness and continuously monitor it. And you would have your pulse oximetry, your end-tidal CO2 monitor, and monitor the patient continuously. You want to have an idea about that raised intracranial pressure. Shock that develops in a patient with a head injury may be the result of hypovolemia. So administer glucose to a head injured patient only in case of confirmed hypoglycemia. So infuse isotonic crystallites for hypotension. Continuously monitor the patient's blood pressure. Do not allow the patient to become overheated. Remember, they can lose their control of their temperature and regulation, and so you have to monitor that for them. So it's your fluids as needed. For a scalp laceration can contribute to hypovolemia in any patient. As we said, the scalp is very vascular and you can have large blood loss. Use a dry sterile dressing and fold any avulsions back onto the skin bed. Do not apply excessive pressure to open wound because we do not want to compress any brain tissue. Immobilization of cervical spine, stabilize head and trunk so that potentially fractured bone fragments do not cause future damage. Again, we are talking about spinal motion restriction, so you carry out your procedures appropriately. We say that we cannot, it's hard to fully mobilize the spine, so it is to provide that spinal motion restriction as needed to minimize the movement. Do not move the head any further in cases of muscle spasm in the neck. So if you're attempting to place the head in neutral alignment and you encounter resistance, do not go against resistance. Increased pain with movement, numbness, tingling, or weakness in the arm or legs, compromised airway or ventilations. So if you have any of those, it's indicated not to move the head any further in the cases of those. So for a spinal injury, cervical colors, you would carry out your procedure, provide preliminary partial support, assess for PMS. So once you are going to be doing any splinting process, it is the full lung backboard is a full body splinting operation you're carrying out. So it's always gonna be PMS before and after. Ensure that you check your PMS before you're doing that splinting process on the backboard and after. Maintain manual support until the patient has been fully secured to the backboard. So the person at the head will have to maintain that manual stabilization until the patient is fully secured on the board. We don't want to see you at the head helping with strapping off the patient and releasing one hand or two hands and not securing manually. So preparation for transport, several types of long backboard. You have your scoop board, immobilization devices that provide full body spinal immobilization. As we say, in its spinal restriction or spinal motion restriction are available, designed to stabilize and immobilize the head, neck, torso. So what is available in your jurisdiction and area, what's follow your protocol. For your seated patient immobilization, you have your Kendrick extrication device. So common short immobilization devices are the vest type and the rigid short board. And you should all know how to use them and know their limitations. Supine patients, 4-person log roll, ideal procedure to move a patient from the ground to the backboard, slide the patient onto a backboard or use a scoop stretcher, ensure that the head, torso, and pelvis move as a unit, and that's the critical part of it. You know, it don't make sense here moving the patient and you're compromising the same thing that you're attempting to protect. So that is counterproductive. So ensure that everything is done with alignment, total alignment and coordination. Scoop stretcher and vacuum mattresses are other alternatives, especially for your geriatric population. For a seated patient, we said earlier on, you're gonna use your short backboard or vest style spinal extrication device. Popular one, we have the Kendrick extrication device to immobilize the cervical and thoracic spine. Only use these spinal immobilization devices in patients who are stable and do not require rapid extrication. So once there is compromising of the ABCs, you do not have enough time to stay to use your head or your short backboard. You need to get that patient out of the area. So the patient is in the car and their area is compromised, you need to manage it. You don't have time to be putting on a short backboard or vest style. It's going to take more time than you require for that patient. So you need to do a rapid extrication to get them out quick. So you need to just get them out as best as you can, still trying to protect their spine as best as possible, but you need to get them out. So it's indicated when there is rapid extrication is indicated only in cases of life or limb-threatening injury. You need to rapidly extricate them because it's gonna be life over limb in that case. Even if you risk compromising the spine, at least they will survive with, but it's all debatable, I guess, because some person might say better if they leave me than save me, I'm paralyzed. But we are gonna be erring on the side of saving them. So these are questions we need to ask our patients when treating a patient wearing a helmet. Is the patient's airway clear? Is the patient breathing adequately? Can you maintain the airway and assist ventilation if the helmet remains in place? Can the face guard be easily removed to allow access to the airway without removing the helmet? How well does the helmet fit? So these are considerations you will take in place when you have a patient in a helmet, because the helmet will can help in stabilizing that patient head. And so you need to decide if it's really need removing it. In the case where you don't have to, then it's better to leave it in place. And these are the questions you will need to ask to determine if it's gonna be affecting the way how you manage their airway, then it need to go. If it is not fitting tight, then you need to move it because it's still gonna have movements within it. So all of that will determine whether you need to remove it or not. Also, you can ask, can the patient move within the helmet? Can the spine be immobilized in a neutral position with the helmet on? A helmet that fits well prevents the patient head from moving and should be left on. Specific conditions require helmet to be removed, as we said. Sports helmets are typically open in the front and may or may not include an attached face mask. So again, it is first you'd have to remove the face shield, and then you proceed to remove the helmet if it's needed to be removed. Motorcycle helmets often have a shield covering the face. Again, remove the shield, then you remove the helmet if you need to. Preferred method technique for helmet removal depends on the actual type of helmet worn by the patient. Consult with medical direction before removing a helmet. Follow your protocol at all times. If they say you can go ahead and do it based on your standing order, then you do what you need to do. If you need to get permission online, then you get it. Once you're not sure, call in and verify, but it's not everything you're going to be calling in for. You should know what you're allowed to do and should be able to do it. Alternative method, allow the helmet to be removed with less force, slightly more time consuming. And we have the steps. We have those steps. You can look at it in your book. So basically, we just you start by removing the chin strap, remove the face mask or the face shield, pop the jaw pads out of place using a tongue depressor. Place your fingers inside the helmet during removal of the helmet to gently rock it back off the top of the head. The person at the side of the patient controls the head by holding the jaw with one hand and the occiput with the other. Insert padding behind the occiput to prevent neck extension. So one person would be at the head back of the patient head, maintaining that manual stabilization, while the partner, the lead person, would be doing that initial movement and then follow through with the person at the back of the head, finishing removal and stabilization. Small children may require additional padding to maintain a neutral inline position. Again, we say because of their size of their head in proportion to their body, you need to pad beneath the shoulders so that they can maintain that inline position. So padding is important to maintain airway. Place blanket rolls beneath the child and the sides of an adult size backboard. Again, that's what we're gonna use, so you need to pad all the areas, and that's why we say it's hard to fully mobilize the patient's spine, but we do our spinal motion restriction as best as possible. So follow your protocols. Back pain is non-traumatic spinal conditions. So there is no trauma involved, but the patient has some spinal problem. So patient will complain, some patient might complain of back pain, and that's one of the most common physical ailments. Upright posture places a substantial amount of weight on the lumbar spine. So persons who are working at their desks for long hours can have these problems. Spinal tumors can also cause pain and debilitation. Most cases of low back pain are idiopathic. Pay special attention to the patient's medications. That can clue in as to what's happening. And as we come to the last slide in this chapter, tumors in the spine from a variety of metastatic carcinomas can cause pathologic spine fractures. So these are osteoporosis of the bones and can affect the spine. Generic disc disease is quite common. Substantial narrowing may result in variable segment stability. This herniation may be caused by some degree of trauma. Prehospital management of low back pain in the absence of trauma is primarily palliative. So we are just gonna give them supportive care, manage the ABCs, and provide transport. We have come to the end of head and spine injury chapter. Any questions?